So to start off with, the sacrum and coccyx, what we're looking at, we know that the sacrum attaches to L5. The sacrum itself is 5 fused vertebrae together, and then that would be the main portion of the posterior part of the pelvis. Along each side of the sacrum, on the right side and the left side, the ala or the ilium attaches to, and that joint space is called sacral iliac joint of the right side and the left side, to be more specific. And then inferior to that, the coccyx is basically our tailbone. They say it's roughly 3 to 5 fused vertebrae. At one time, and through evolution, we lost the tail. There are still genetic abnormalities that occur that some children being born have a little nub where the coccyx is, which is like a little tail. So to move forward here, so 5 fused sacral segments, it would be considered a primary curve, same direction as a thoracic, so it'd be a primary, wedged between the iliac bones of the pelvis on either side, and as I stated earlier, where they meet together would be the SI joint. The prominent features would be the promontory, canal, foramina, and cornu. So I'm going to go backwards here. The promontory is the anterior body of the sacrum, where it meets with L5. It's basically the first segment body of the sacrum if they were separated. The promontory is on the front side of, anterior side of the superior portion of the sacrum. The canal you cannot see on an AP view. The canal runs along the posterior side of the sacrum. It is actually similar to the vertebral canal of all the other vertebrae of our spine. It is literally a canal where the sides of the sacrums come around and form a canal that runs all the way down through. The foraminas. Foraminas are only seen on the AP. Foraminas are similar to what we have in our cervical. That would be the transverse foraminas, or the intervertebral foraminas that are created with 2 vertebrae. They're basically holes, at which point some nerves and other things do run through them. The cornu is, well, let's see. The cornu lies in the inferior portion of the sacrum, and they're basically like little horns that help connect up the sacrum to the coccyx. Kind of hard to see it on an AP or a lateral. If you can find an oblique of it, you'll find 2 little bony protuberances jetting inferiorly, called the cornu. So once again, the promontory up at the top, foraminas. The canal would run along the posterior side of the segments. The cornu would be on the posterior side, bony extensions that angle inferiorly. The coccyx is known to have 3 to 5 vertebrae, fused vertebrae, or rudimentary vertebrae. Not necessarily always fused, but you can definitely tell that that there are 3 to 5 segments. In this image, the prior one, you can see 1, 2, 3, and 4. This one only had 4. The one before that, 1, 2, 3, exact same picture, 4. So it can have anywhere between 3 to 5. Curves inferiorly and anteriorly and articulates with the sacrum. The interesting anatomical feature of the coccyx is that it also has a cornu, which is on the superior portion. Like I said, inferior, the sacrum would have a cornu jetting inferiorly. The coccyx has one that actually jets superiorly on the posterior side of the coccyx. Okay. Okay. That was anatomy, but let's go over, if we remember, some of our our landmarks. Do we remember A?
Pubic symphysis.
Okay. B? As is, correct. At what level?
S1, S2.
I think it's 2, 3, isn't it? You may be correct. Let me
Pretty
check.
sure it's S1, S2.
Yeah, S1, S2, you're correct. C at the crest?
L4, 5.
4, 5. D at the inferior angle of the rib mark. L2, 3. That is correct. Or between L2 and 3. And E would be the xiphoid tip is at what level?
T9 and T10.
T9, T10. Very good landmarks to know. Okay, going to the positioning. So we're going to start off with the SI joint. SI joint, we're going to be doing AP axial, so the patient will be positioned supine. We're going to do AP obliques, which means that the obliques are going to be either RPO or LPO, correct? Okay, so to start off with, the SI joint, we're going to use an 8x10, 10x12. If you use an 8x10, I would put it in portrait, or excuse me, landscape. Put it in long ways, landscape. 10x12, you can do either way, because what we're looking at are the SI joints are at the widest portion of the sacrum where it connects up to the pelvis. It is a 40-inch SID. The amount of angulation is anywhere between 30 and 35 degrees, and it does depend. Females, you will need to go more. Males are less. Because of the natural curvature of the sacrum, is greater for the inlet on a female, so it angles posteriorly more. So you will have to do more angulation. The central ray is along the mid-sagittal plane, about 1.5 inches above the pubic symphysis, or they also say 2.5 inches below the iliac crest. So being that we're angling cephalic, where does that put the pubic symphysis? Up high or low in the image?
High.
Would it be low for elongation?
Okay, so I heard high and low. Mia had a high with a question mark on it. You want to justify your answer?
No.
No, please. You're thinking correctly.
I'm gonna go with Mia's.
Okay, Brian, you got to vote for Brian. Carvin, you said something?
No, I said I'm gonna go with high also.
Okay. So Mia is correct. It will bring it more superior when you have a cephalic angulation to it. So note that if there wasn't or first of all, what we're looking at here are the SI joints along either side. 1.5 inches above the pubic symphysis or 2.5 below. We can even tell that they're centered right at about the first segment of the sacrum. It could be a little bit lower, not much. But because of the fact that the pubic bone has a shorter SOD, source to object distance, than the sacrum does, it is going to be projected more with the angulation in the direction that you're angling. Makes sense? So if we have the sacrum down here, we have the pubic bone up here, we throw an angle, the tube will throw the object closest to the source more in the direction. Hence why we see the symphysis pubis being riding up high. I only bring this forward because it's different than what we angle specifically for sacrum. So to differentiate between an SI joint and a sacrum, one of the tell signs is the pubic bone, but also the foraminas. Note how the foraminas are closing off. It's because we have too great of an angle to match the foraminas of the sacrum and the angle of the sacrum within the body. Because of the angle, it's closing them off. But when we get to the sacrum, note how they are open. I want you to be able to differentiate and really break down an image to figure out, am I shooting it for an SI joint or am I shooting it for a sacrum? Because they look basically the same. So we can see the promontory of the sacrum here. We see the body of 5, and we see the SI joint on either side bilaterally. For the oblique, we are looking at the SI joint furthest away from the IP, the side up, if you want to go that direction. Note that the SI joints lie at this angle. So we have our sacrum in the middle, we have the olives coming around, and the SI joints are at an angle. So by rotating it up, side up, it puts it parallel with the source and perpendicular to the IR. Note by rotating this pelvis, we're looking down through the SI joint that is furthest away. If this was rotated flat, you'll see that the angles of the SI lie at an angle. So, ways to visualize and remember is that the SIs are at an angle, rotating up. I'm looking at the side that is parallel with the IR, or parallel with the source, perpendicular to the IR. The amount of rotation is 25 to 30 degrees. So 8 by 10, and in this situation, if I use an 8 by 10, I would do it in a portrait. Brian, you raised your hand?
Yeah, is there also a cephalic angle as well as when we rotate the patient?
No, there is not. It's perpendicular.
Thank you.
It is perpendicular. 40 inches, we're going to center 1 inch medial to the upside as is. So we find the as is, which is actually down here on this patient. I would say the crest would be about here. His umbilicus as is maybe about there and 1 inch in from there medially. Rotate the patient 25 to 30 degrees, and I put log roll. For those of you that I worked with last week, and for those of you that have done and performed lumbar spines, when you ask the patient to roll to an RPO, let's say, have you noticed that that patient scoots their hip before they roll?
Every time.
Isn't that wonderful? Frustrating, huh, Andy?
Yeah.
And why they do it is, I don't know why they do it, actually. I don't have a good reason for that. What I've learned is you have them positioned for an AP, perfectly positioned, mid-sagittal plane, etc. Then when you try to roll them, they scoot their hip and now it's at an angle. Correct? So my trick is to log roll them. If I was placing a patient in an RPO, whether I was doing it for the lumbar spine or for the SI joint, doesn't matter. I would ask the patient bring their left hand to the right shoulder, bend up their left knee, and I lean over the body and have a 45-degree sponge. And without scooting the hip, I tell the patient, roll like a log towards me. And then I put the pad behind them, the sponge behind them. That way they're still on the long axis of the table. There you go, Drew.
So the side that you're rolling to, you keep that arm and leg extended, and then the other side bends.
Correct. But the main point is telling them not to move their hips. It's the first thing they do every single time.
I think maybe people do that as like a reaction to prevent falling off the edge.
That's
I
part of
mean,
it.
that's what my, the population I work with, geriatric, they always kind of like, try to scooch their body on the side that they're not rolling. You know what I'm trying to say? So
Exactly. And hence why when if I was placing the patient in RPO, I'd use my left arm against their hip and shoulder. And as they rolled, my body would be against them so that they would not fall. Or I would tell the patient, you're not going to fall off the table.
yes.
And if I was doing the LPO, I go around to the other side of the table. Because you don't want to push a patient up and off. That's what they're going to feel. So walk around to the other side and do it.
It's pretty amazing that when you communicate with your patient and you reassure them of things like that, especially with the geriatric population, their trust in you will grow exponentially, and then they'll follow your commands a lot easier. You know what I mean?
That's very true. Very true. And being very concise and knowing that they're not going to fall or putting your body in front of them will help them. So getting back to the SI joint on the left side, the patient would be placed in RPO. You would log roll them into a 25 to 30 degree rotation and center 1 inch medially to the upside as is. And this is what we see. We see the SI joint. Now, I did make mention of placing an 8x10 portrait because we're looking at the long axis of the SI joint. It means if we center correctly from the as is 1 inch medially to it, we should be able to collimate side to side also. And in this position, we should also remember that the patient in this position is what, an RPO, correct? Remember how I was talking about the Scotty dog? Remember how I was saying that the ala would be more on plane with the tube or perpendicular? Notice how short the ala is compared to if we saw the other one, it'd be rounded out, which means that the Scotty dogs are looking towards the
Left.
right,
Right.
side,
Right. Oh.
towards the right. So you can add all of the routines together here that we're talking about and really get a better picture and critiquing images this way too. Okay, going to the sacrum. Yes.
For obliques, so we're collimating to the one SI joint?
Correct. Because if we do bilaterally, this one's flattened out. We won't see through the joint. We're only looking at the side up. Okay, sacrum and coccyx. Sacrum would be an apiaxial and a lateral. Coccyx would be an apiaxial and a lateral. AP-lat. That's what we're doing with an angle. But when the sacrum or the SI joint was 30 to 35 degrees cephalic angulation, the sacrum is only 15 degrees. So let's get into it. By the way, has anyone done a sacrum and coccyx? Yeah, you have? What do they also call them? Do they give it any name? Oh, I'll talk about it as we go and see the images. Okay. For the sacrum, 15 up, 10 down for the coccyx. Brian.
Sorry, I'm just having trouble with these emojis. I can't get rid of the yes now.
Okay, fair enough. The way to remember, how many toes do we have? 10. So 15 up, 10 toes down. Angle 10 down towards the toes, 15 up. Easiest way to remember. Helpful? Okay, thanks, Andy. Okay, now we're going to get into something even more helpful and more easy, or helping you to remember where the central ray goes through. We know the spine is along the mid-sagittal plane, correct? We know that the sacrum and coccyx are attached to the spine, so it's going to be in the mid-sagittal plane, as you can see in the picture behind me. For the sacrum, 8 by 10, 10 by 12, 40-inch SID. Remember to drop your SID down 1 inch for every 5 degrees to maintain the 40 inches, or change your technique. The central ray is 2 inches above the pubic symphysis. (15-degree cephalic angulation, patient is supine, and suspend the respiration. Why I jumped the slide and went to this is that the central ray for a axial sacrum is centered 2 inches superior to the symphysis pubis, and for the coccyx, it is centered 2 inches superior to the pubic symphysis with a 10-degree caudal angulation. They're exactly the same. So the trick there is, once I know where the pubic symphysis is 2 inches above, I put my 15-degree cephalic angulation, because we normally start with the sacrum, and I take my image, I place my finger on the side of the body where the light is going through, turn my tube 10 degrees caudal, run it down the other way, line it up, move my bucky down. So I'm centered exactly at the same spot. You may want to put a line on their gown. I don't know. You may want to put a pin on the side so you know where it's at, so you don't have to palpate again. Should only have to do it once. 15 up, 10 down for the coccyx. Fair enough? Okay. So I will get back to that other slide. So this is what we should see on a sacrum. Note how the pubic symphysis is a little bit lower. Note that the foraminas are rounder and more open. That means there's less of an angle. I'm going to go back to the SI joint. Note the foraminas, how closed off they are. You can kind of see that one, that one, that one, that one. It's matching maybe because of the angle of curvature of the sacrum. But this one's more of an oval. This one's an oval compared to, look how much rounder they are. They're quite a bit rounder. And note that the sacrum is 5 fused vertebrae, correct? So 1, 2, 3, 4, 5, and this would be coccyx down here. Flipping back. 1, 2, 3. Hold it. Let's see. 1, 2, 3, 4, 5. Coccyx is way down here. Pubic bone is covering it. Superimposed. Note how the inlet of the pelvis is foreshortened also, compared to. Note that it is a little bit larger. And these are the different or subtle differences that you'll be able to see to be able to differentiate between a SI joint and also a sacrum. Yes, Andy. You got a question? Oh, it looks like you were going to your computer. No, okay. For the axial AP of the coccyx, 8x10, 40-inch SID, 10-degree caudal angulation, centered 2 inches superior to the pubic symphysis. 2 inches above the pubic symphysis, 10-degree caudal angulation. Suspend the respiration. So note that the 10-degree caudal angulation is centered exactly at the same point. And what we should see now is because of the angle going caudally and that the pubic bone and the SOD is the least amount or closest to, it should start projecting the pubic bone down so that we can see the coccyx that is closest to the IR. So we're looking at 1, 2, and 3. 15 up for the sacrum, 10 down for the coccyx. Normally, you will not see a clear coccyx. Normally, it will look like this. What's the black? It's air.
Ladder.
Air.
Fecal matter.
You would see more of a modelly density to it. Black is always air. That's gas. Or you may see fecal material in front of it, which obscures a true good axial AP of the coccyx, or even of the sacrum. So the real money shot of a broken coccyx is the lateral. We're going to go back now to this slide. The positioning of the lateral is very specific, as it is for the L5S1 joint. Specifically for the sacrum, it is 3.5 inches posterior to the as is. Period. That's where you center. For the coccyx, it's 3.5 posterior and 2 inches inferior for the coccyx. So I'm going to move forward here. Here's the lateral sacrum. 8x10, it's going to be done in a portrait. 40-inch SID, 3.5 inches posterior to the as is. So left lateral, we would find the as is on the anterior side and run 3.5 inches posterior. Note how they did use a lead blocker here to pick up any scatter radiation to clean it up. Suspended respiration, true lateral. Note that we can almost tell that this is probably where the crest of the patient is, compared to the crest would be up here and we're centering lower. So 3.5 inches posterior for the lateral coccyx and 2 inches inferior to the as is. Here's the as is up here. They went 3.5 posterior and inferiorly 2 inches below. Note the collimation and where the light is in relationship to differentiate between these images, whether it's a lateral sacrum or a lateral coccyx. I'm going to go back. Note how much higher it is on the crest. You can take it off the band, I'm not sure, but compared to, there's a band, there's the crest up here, up higher. This one should be collimated even more, I would think. So to look at the images, this is what we would see for a lateral sacrum. And do note, the coccyx is included. Whether it's from the collimation or positioning, this is a good, true lateral of the sacrum. So the crest would be at L or L4, L5, which is here, as is would be down here, and they went posterior, 3.5 inches. 3.5 inches posterior, 2 inches inferior should get you to the coccyx. Personally, I like to rotate my collimator in the direction of the sacrum. So my sacrum would, or my collimation would be more in this direction. And I like to place my marker on the anterior side, specifically because of the curvature that we have here. We get the most room on the anterior side there. There is a coccyx. Note how they did collimate off part of the sacrum, and they're only looking at the section of the coccyx. I think I've done 2 or 3 broken coccyx in my time. And it's usually from slipping and falling and landing flat on their butt or their gluteus maximus, or however you want to say it. And I've seen it angled inward. It can be very painful, but are they going to do anything to help it heal? Nope. They send the patient home with a inner tube, a donut to sit on. Yeah, that's about it. That's about all they do. So note the difference between a lateral sacrum and a lateral coccyx. Now, if I'm correct, do we have Marissa here? No. They're up at AG, they, on their L5S1, they like to include the sacrum and coccyx. So there's variations that you'll find. Another way to position correctly is, I might find the sciatic, or the 2 dimples, and place my hand around, and I know that it's just a little bit anterior to that and inferior. But know the exact positioning for the test, if you would. Okay, this has been coming up quite often, and I wanted to go back over this slide because it's very important. I see it on the national board, and I hear it from my seniors right now. And how are they going to remember what they're looking at in the different positions of the spine? So, starting off with the cervical, to look at the intervertebral foraminas, we have to do a 45 degree. We have to rotate the patient 45 degrees. And whether we do it AP or PA depends on what side we're looking at. Know that. So if the patient is placed in an LPO with a 15-degree cephalic angulation, what side are we looking at? Patients in an LPO, 15 cephalic, what side are we looking at?
Right?
Correct. Mia, 2 for 2. Good job. If the patient was in an RAO, 15-degree caudal angulation, what side are we looking at?
Right?
Correct. The right side. You have to know that for the cervical obliques, which side you're looking at for that part of the intervertebral foramina. Now, the zygopophyseals are seen in a lateral. Don't ask me why this is here now. So zygopophyseal joints are in the lateral. Not sure what they're referring to there. Now, when we go down to the thoracic, the intervertebrals are seen in the lateral position, as well as with the lumbar. The thoracic and lumbar are the same on the intervertebral foraminas, and the cervical is the opposite one here at 45. So imagine looking at a lateral T-spine or a lateral lumbar, you'll see the intervertebral foraminas looking at you. Visualize it. Now, we're going to start down here with the lumbar, because we do more lumbar than what we do for the thoracic obliques. We rarely do thoracic obliques. The amount of rotation can be anywhere between 30 and 60 degrees. On average, we do 45. But if we really evaluate the Scotty dogs, they'll look good in the upper, but 4 or 5 will look really terrible. You start losing the Scotty dog. So you can either do it AP or PA, but if we're looking at the AP, which means that the patient is in a correct? RPO, LPO, we're looking at the side down, the direction of the dog. The nose of the dog is pointing to the side down, and the ear is part of the ZA that we're looking at. And the lower foot is the other ZA we're looking at.
So for the cervical, the AP side up and PA side down is for the obliques.
Correct. Correct. I have to visualize it in my head because I do a PA and I know I'm looking at the side closest to. I just know that. So now for the PA below, we're talking LAO and RAO. Then we're looking at the side away. So if the patient was in an RAO, what side are we looking at? Left. Because now the ala of the pelvis is flatter. In an RAO, we're on our right hip more, meaning that the pelvis or the ala on the right is foreshortened. I know if this doesn't just scramble your head. Yeah, I can see it. It's, for me, I think the easiest way is to start with the intervertebral foramina. Know that the lateral T and the lateral L is where you see the foraminas, which means the opposite would be for the cervical. Cervical is on the oblique. For the ZAs, we see the ZAs on the lateral for the cervical and the obliques on the thoracic and lumbar. Now we get into the thoracic ZAs. The amount of rotation is 7 degrees from an AP or APA. So, once again, if it was done in an AP, that means we're looking at a RPO and a LPO, correct? And they're saying that you're looking at the side up. So if the patient was placed in an LPO, what side are we looking at? The right. Andy? Looks like you were going to say something.
I wasn't listening. I didn't know if you're doing L or thoracic or cervical.
Oh, thoracic. Thoracic. So if we do it PA, which rarely is ever done, rarely, they're saying that the patient would be now placed in a RAO and a LAO, which means that we're looking at the side closest to the IR. So if the patient was placed in an REO, we're looking at the right side.